Hello everybody, I'm going to do my lecture on the respiratory system, and the first part of this is going to be a repeat of what we did in class and continuing on to structures that I didn't talk about in class. This will serve as your lecture for those structures. So I'm going to start off really quickly. We're going to be going through the first two objectives here, the functions of the respiratory system and the major organs, and then we'll be getting to the rest of those objectives in further lectures. So here's our functions of the respiratory system. Air distribution, this is going to be basically the ducts, the ducts that are going to be carrying air from the outside of our body to the inside of our body. And then gas exchange, which will be taking place at the alveoli. Homeostasis is maintained by making sure that we have enough oxygen to break down glucose in our mitochondria, and then as well as maintaining the pH level of our blood, because carbon dioxide breaks down into carbonic acid in our bloodstream. Okay, so to continue on, so we have pH values are maintained. That helps to maintain homeostasis, as well as the necessary exchange of oxygen and carbon dioxide. Filter, warming and humidifying air. This is accomplished by the nose. The pharynx, very important for airstream. Oh, sorry, it's late. Sorry about that, you guys. Now you're all going to be yawning, huh? Speech and sound production. These are our vocal cords. Actually, I think it's C-O-R-D-S, right? And then olfaction, which is our sense of smell. Okay, so all of these things, one way or another, our respiratory system is involved in. The plan of the respiratory system, it looks like an inverted tree. That means a tree that's turned upside down. The actual gas exchange is in the alveoli. And because this process happens through diffusion, we have to have a single cell layer, and we need to have a very large surface area. So single cell layer, we have the alveoli coming down, and then we have a network of blood vessels going all around the alveoli. So you're only going to go through two cell layers when the air comes into the alveoli. It has to diffuse through the alveolar cell and then through the capillary beds. So it's only one cell layer thick. This has to be a really, really thin membrane because diffusion happens very slowly. So you need to not go through multiple cell membranes. You just go through one cell of the alveoli. So you have a simple squamous epithelium. Okay. And then you have the second cell of the bloodstream. So imagine here, you've got your red blood cells in here that are going to pick up the oxygen, right? And you have the O2, and it has to diffuse into the bloodstream. And we're going to get in a lot more detail about that. Okay, moving on. This is our beautiful respiratory tree. This here is the trachea, and it's kind of hard to see, but it comes down and it branches, and then it branches off again and again and again, getting smaller and smaller and smaller. No gas exchange occurs until you get down to the ends of the respiratory tree, to the alveoli itself. Okay, your respiratory tract is divided into two parts, upper respiratory tract and lower respiratory tract. And again, you are not going to get any exchange of gases in the nose, pharynx, larynx, not in the trachea, not in the bronchial tree, not until you get to the alveoli. So if you have a head cold, you actually have an upper respiratory infection. If you've got bronchitis, if you've got something like asthma, that's affecting your lower respiratory tract. Okay. Moving on, this shows you your upper respiratory tree, and then a nice little close-up view of the bronchiole, and then the alveolar duct and the alveolar sacs. So notice, yes, you have to have blood vessels giving nutrition to the tissue up here, but it's not until you get down to this level that you have the alveolar sacs with the capillary beds all around them, because that's where gas exchange is going to be occurring. The respiratory mucosa, this is the cells that make up the lining of the trachea and the bronchi and the bronchioles. And you have special stratified squamous epithelium, or pseudostratified rather. So it's the pseudostratified. Okay, pseudostratified ciliated columnar epithelium with these special goblet cells, and it will be trapping foreign bodies and pathogens, and then the cilia are going to be constantly beating, secreting. Oh, I'm sorry, it's like 9 o'clock and I'm just dead. Oh. So the cilia are going to be beating and carrying the mucus, which has trapped all those particles, up towards the pharynx, and so it's going to be coming up and out. And so every once in a while we do this kind of clearing our throats and a swallow when we're not even aware of it most of the time, and that's going to be then sending that stuff back down through the esophagus into our stomach. So that's how we get rid of the stuff that we've inhaled. That's constantly coming in. We're trapping bacteria, dust, dirt, pollen grains. So our body wants to keep that from going into our lungs any further, and so it traps it in the mucosa. So then we have, this is a nicer close-up view of the ciliated layer there with all these different types of cells, the serous cells, the goblet cells that create the mucus, and then the cilia, how it moves it on across. There's another picture of it. So again, this is moving up and out of our respiratory system. So starting with our nose. Our nose is lined with mucous membranes. We have 2 nostrils. They're called also nares. Those are our nostrils. Separated by a septum, just like the heart was separated into 2 sides, the nose is separated into 2 sides, and it separates the 2 sides of our nose. It's made of cartilage. The whole tip of our nose is made of cartilage, and hopefully you remember it's hyaline cartilage. And the mucous membranes of the nose are then continuous with the membranes of our sinuses. And the purpose of our nose, and the fact that we have this shell-like structure inside of our nose, is to warm and moisten the air that we inhale. Also, up in the top part of our nose, we have extensions of the olfactory nerve, and that allows us to smell. So when you get a sinus headache, a headache like some of you may be experiencing with the winds that have been blowing, you have this pain in your face, especially if you bend forward, you feel pressure in your face. And that's because of the pressure differential between the sinuses in your head and the pressure outside. So what can happen is when you get inflammation in your sinuses, it can block off the connections that should allow for gas exchange between these different sinuses, these different pockets in your face. And what will happen is that the pressure of the inside of your sinus is different than the pressure outside of your sinus. And so this pressure difference is why you feel the pressure on your face and you get a sinus headache. And this can happen just when you're, walking around right now and the wind is blowing the way that it has been, and you build up this pressure difference between your face sinuses, your facial sinuses, and the outside environment. And it pushes, literally, if you have a lower pressure outside compared to the pressure, lower pressure inside of your sinuses compared to the pressure on the outside, you're going to feel that pressure pushing in on your face. So sinusitis is inflammation in the sinuses, and you can have extra mucus being secreted, and you get all congested, and it's not pleasant. Sometimes you have to take antibiotics for it to clear out a bacterial infection. Gosh, my brother-in-law had to have his sinuses scraped out and packed. He was so infected that they had to go in through his nose and pack gauze into the sinuses, and medicated gauze. Yeah, so not pleasant. And what goes in has to come out, so they had to pull it back on out. Ugh. Not good. So how do you know if you have a sinus infection versus just a cold? Both of them are going to give you coughing, sneezing, headache, sore throat, stuffy nose, fatigue, and fever. But sinusitis, okay, or potentially a sinus infection, is that feeling like you feel like someone has been spinning you around in a chair. Every time you move, you have problems with your inner ear. You have a thick yellow or green mucus. Postnasal drip, which is going to give you bad breath. Postnasal drip, you'll have a really sore throat when you wake up in the morning. Pressure behind your eyes, especially upon bending forward. Okay, and then fever, of course, if it's a bacterial infection. And so this picture of the lady over here, this is something called a neti pot. And I have not used one myself, but people swear by these things. You put warm salt water in this, and what it does is it literally washes that warm salt water up in through one nostril. And remember, they aren't connected down the middle. So they're connected through the sinuses. So it puts this warm salt water up, washes out your sinuses, and then it comes back out the other nostril and rinses you all out. And people swear by this. And they say it's especially if you have sinus issues, it feels really, really good. I have not used one because I just can't imagine pouring water up my nose, but I've heard they're the best thing ever, so I don't know. Okay, so the pharynx. The pharynx is your throat. There are 3 divisions, okay? The upper part of your pharynx by your nose, the oropharynx at the back of your mouth, oro for mouth, okay, nasal, and laryngopharynx by the larynx. Okay, so it's upper, middle, and lower, okay? Upper, middle, and lower. These are also lined by mucous membranes, just like your nose. And all of these have sinuses that dump into them. Your eustachian tubes from your ears dump into them. Your nose dumps into them. So, we eat through this opening. So it's a huge, I guess, what I want to say, a convergence of a lot of different systems coming together. And this is why people can, if you've had a drink of milk or something and you laugh in the middle of your swallow, you can actually shoot milk or soda out your nose. It's because it's all connected through the pharynx. This is why ear infections can occur if you have an infection in your throat, because your middle ear is connected through the auditory tube. So, and this is the position of your tonsils. I had to have my tonsils out, and what they take out are the palatine tonsils, because mine became so infected all the time. Sometimes they also take out the pharyngeal tonsils, the adenoids. Okay, so they do that procedure by going in through the mouth and taking them out, kind of just scooping them away. This is something that some of you may have seen. These are tonsil stones. Your tonsils have pockets, and they can get food and dead skin cells and things like that in them. And you can get these hard clumps of material inside your tonsils, and these are tonsil stones, and a lot of times people get their tonsils removed. This little structure here is called the uvula, and that also is, if you touch your uvula, a lot of people will gag. That's part of kind of a safety mechanism so that we don't swallow something that might obstruct our airway. And then back here, that would be the oropharynx. okay? Right here on this side, this is the other tonsil, and it's actually probably right there. You can see how this one's all distended because of the tonsil stone. And you can actually like pop these out. These are pus pockets on your tonsils, big long uvula there, but these are pus pockets, which are patches of infection by someone who's got strep throat. So, ouch. Best thing to do there is get on some antibiotics and gargle with warm salt water. Okay, so some structures here to highlight. So you have two parts to your palate. Your palate, the roof of your mouth, your hard palate and your soft palate. So if you take your tongue and run it on the top of your roof of your mouth, you'll feel a ridge. And then way in the back, once you get back here, it's actually soft. That's because this front part here, the hard palate, there's bone. And then back here, this is all going to be soft palate and soft tissue with no bone inside of it. Here we have the three parts of our pharynx: nasopharynx, oropharynx, and laryngopharynx. Down here, we have a really important structure called the epiglottis. The epiglottis closes and creates a protective flap that closes over the opening to your lungs, which is your trachea, so that when you're swallowing, it flips closed so that food goes down the esophagus and that goes to the stomach. This is how we don't want to, when we're swallowing, we don't want food to go down our trachea, which goes to the lungs. So we have that protective epiglottis. This is why your mama always told you, don't talk with your mouth full, because a piece of food might accidentally fall down in there and then, you know, you're choking. That's no good, huh? All right. We have two openings that are really close to each other, right next to each other. One is the passageway for food and liquids, and then that's the esophagus, and the other one is the passageway to the lungs. So the pharynx is a fork in the road, basically, where we have to have a division of materials where they're going. At the top of the pharynx, or at the bottom of the pharynx, right at the junction where you're going to move into the trachea, we have the larynx. The larynx is where our vocal cords are seated, and the thyroid cartilage is going to be what is going to become enlarged in a male and give you the Adam's apple, and that happens at puberty because of extra testosterone. This is a picture of your vocal cords and what they look like if they have polyps or nodules, and what they look like if they're normal. And then make sure you watch this YouTube video here, because it shows how the vocal cords vibrate when the air passes over them. So we actually produce sound when we're exhaling air over our vocal cords. All right, so the larynx is multiple pieces of cartilage put together. Again, as I said, the thyroid cartilage is the Adam's apple, which becomes enlarged during puberty. And then we also have the epiglottis, which is that protective covering to keep us from choking. Functions of the larynx: to distribute air, to separate well, not to separate. It's like the pharynx is where we have the divergence between the esophagus and the trachea. The larynx is to move air and to produce sound through the vocal cords. Okay, the trachea. We're moving down deeper into the chest cavity. The trachea is about 11 centimeters, 4.5 inches long, and it has C-shaped rings of cartilage. I'll explain that in a second. It's also lined with mucus, and it is a ciliated epithelium, and no gases are being exchanged. And so this is just a conduit. It's just a passageway to move air. So when we say there's a C-shaped piece of cartilage, the larynx has to stay open. So if I did a cross-section through the neck you would find the esophagus on the back side, posterior. So this would be closer to the back of your neck. And then the front side, the anterior side, so anterior, posterior, right? Anterior side, you can actually feel your larynx if you run your fingers up and down on your throat, and you feel the ridges of the cartilage. The cartilage is not continuous. It doesn't go all the way around. We call it a C-shaped piece of cartilage. See, it's like that. And that is there just to keep your windpipe, your trachea, open. Lumen, that's just the space, okay? So your esophagus actually collapses. It doesn't have cartilage keeping it open all the time. So it'll collapse and open up as food moves down the esophagus, whereas the trachea stays open all the time. And so can you imagine what happens if a piece of food falls in there? Well, then it blocks the airflow. That's why we don't talk with our mouth full. So, a tracheotomy, okay, a tracheotomy. So sometimes if a person is having breathing difficulties, or if they have to be put onto a ventilator, a machine that's going to breathe for them for an extended period of time, they'll do something called a tracheostomy. And that's where they go in between the rings of cartilage and they insert a tube, and you'd be hooked up to a machine that would breathe for you. They can go in and put these in and then remove them at a later time. The trachea is really important. I mean, this is the only way we're going to be getting air into our lungs. And so choking obviously is a problem. You guys have all heard of the Heimlich maneuver, how we keep someone from choking or dislodge choking material. So there's different methods for doing this. If you are observing someone choking, you stand behind them and you do pull in and up. But the first thing you want to do is you want to ask them, can you talk? If someone is choking, they can't speak. They could be having chest pain and clutching at their chest, but they can talk. Well, then that's an indication they're having a heart attack. If they can't talk, then that's an indication they're choking. So if you're alone, you just supposed to thrust yourself over the back of a chair to dislodge the whatever is blocking your airway. Heimlich maneuver for a child. If they're older, you kneel behind them, and if they're an infant, you hold them in your arm with their heads down and you hit on the back. And of course, that's Heimlich, the beautiful caterpillar. So from the trachea, we branch into the right and left bronchi. And those primary bronchi become smaller, secondary bronchi, and then they get to bronchioles. Again, smaller and smaller and smaller tubes. We get into alveolar ducts, and then alveoli, the little sacs individually. We do not have any gas exchange until we get down to this level. This is where we have the alveolar sacs, and there are millions of them per lung. Remember, if you laid these out side by side, they would cover a tennis court. So a huge amount of respiratory membrane. And remember, this is microscopic. So all of this stuff up here is just getting the air down to the actual structures where gas exchange is going to actually take place. Once you're in the alveolar sac, that's where we have diffusion of gas into oxygen into the red blood cells, and carbon dioxide moving back into the alveolus. So here's beautiful animated diagrams of the bronchioles. Now notice you've got cartilage still holding these tubes open. Okay, and then once you got down here, these clusters of sacs, alveoli, that are where we have the gas exchange. So you don't want to put anything into your lungs that are going to cause disease and clogging up of this material, because then you're not going to be able to exchange gases. So it's bad news, smoking and all that stuff, introducing all that tar into your lungs. So the bronchi and bronchioles, main function, air distribution. The alveoli, this is where we have gas exchange through the thin walls, direct contact with the blood capillaries. So you're only going, again, through 2 layers. And then we're going to introduce this thing called surfactant. Surfactant is a soapy type of material that decreases the surface tension inside of the alveoli and allows them to open up more easily so that we can so they can inflate every time you inhale. Okay, so when we are traveling on our way to our alveoli, we're going to be passing through tubes that have to stay open. But what happens when you have asthma? Well, remember, these tubes are lined with tissue, okay? Simple or pseudostratified epithelium. And so if that epithelium becomes inflamed and if it swells, or if the smooth muscle that lines it starts to spasm and close the diameter of those tubes, that's going to make it harder to breathe. So when you have asthma, you wheeze because you've constricted those tubes, the bronchi and bronchioles, and the air is whistling as it's moving through. And you're not getting good gas exchange or movement of gas down to the alveoli where you need them. You need the gas in order to be able to actually breathe. The lungs, you obviously have 2. You have 3 lobes or parts to the right lung and only 2 to the left. The left lung only has 2 lobes because there's something called the cardiac notch. And the heart itself takes up some of the space of the left lung, because remember the heart sets kind of left onto the left of the side of the sternum, underneath the sternum to the left. The apex of the lungs is the upper part, and the base is the lower, broader part that sets on the diaphragm. So here's that muscle, the diaphragm, and you have each lung kind of like triangular setting. And we have a little cardiac notch on that one. And then the heart sets off to the side. So there's the great vessels, and then you have the trachea branching down into the bronchi, coming into each one of these lungs. And they sit on top of the diaphragm. Okay, so this is that cardiac notch I was telling you about here on the left lung. And you have different divisions of the lung that are supplied by different branches of the bronchi. It's possible to have to surgically remove a portion of the lung, and you still can survive, and you can survive with just 1 lung. Okay, I'm going to break here, and we'll come back with my next lecture. It's been 28 minutes, so this is running kind of long, and we'll talk about the linings around the lungs and how we maintain pressure and inflate lungs. Okay, see you next time.